From the JAMA Network, this is JAMA Ophthalmology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Ophthalmology.
Hello and welcome to our listeners around the world. You're listening to JAMA Ophthalmology Author Interviews, and thank you for joining us. I'm Neil Bressler, Editor-in-Chief of JAMA Ophthalmology. Today, we're going to look at the effect of the Support, Educate, Empower Personalized Glaucoma Coaching Program, also known as the CSEE program on medication adherence. And joining me is the corresponding author of this randomized clinical trial, Dr. Paula Newman-Casey, an associate professor of ophthalmology at the University of Michigan in Ann Arbor. Paula Ann, thank you so much for sharing this important trial with us.
Well, thank you so much, Neil, for having me. I really look forward to talking about the trial with your listeners.
Maybe we can just start with the purpose of this trial. So I know you were comparing just standard written instructions to people on their glaucoma medication adherence. Are people not paying attention to that? What's the background? Do we find that people are not paying attention to written instructions they're getting? They're not adherent? What did you know before you started this?
Yeah, well, what I knew from being a resident in the VA was that I would have patients come into my clinic and I would be talking to them about escalating treatment and needing more medications or potentially needing surgery. And then 15 minutes into the conversation, it would come to light that they weren't taking any of the medications that I'd already prescribed. I had a particularly poignant moment when I was a resident where an older vet just kind of started crying because he hadn't taken his medication since his wife died, who would always help him. It just started to make me realize that I needed to ask more before escalating treatment if people were having trouble taking the medications I'd already prescribed. That's what got me interested in this area of research. And then when I started looking more at what epidemiological research had already been undertaken and what people had already looked at, it seems like medication adherence is a huge problem and that probably half our patients aren't taking any of the things we're prescribing for them. And if they are, they might not be taking them at the dose or frequency that we're recommending.
This is really a challenge. If you do a treatment in clinic, you know they got it, but if you recommend it for them to do something at home, which is necessary for these glaucoma drops, you just don't know. So what was the intervention you were planning to test? So it wasn't going to be just write down the instructions and here's what we want you to do. What's this coaching program all about?
For years in clinic, I have been writing my instructions down for patients and printing them. And I had this funny feeling that a lot of them were ending up, if I was lucky, in the recycle bin, and if I was unlucky, in the trash basket. And so I thought we really needed to imagine something much more comprehensive. And I did a lot of focus groups with patients and interviews and kind of did some iterative changes in what we wanted to create, what patients might want out of a chronic disease self-management support program for people with glaucoma. And what we found was that people really appreciate attention. And so at the core of our program is a prescribed way of giving people attention in a way to nudge their behavior towards what the doctor would want, but to help them find their own reasons why they want to take care of their eyesight. So hearing from patients what a lot of the barriers and facilitators were to engaging in their glaucoma care, we created a coaching program based in motivational interviewing. And as a doctor, I spend a lot of time telling people what to do. And nurses, we all tell people what to do. And somebody said to me, if somebody tells me what to do, I may or may not do it. But if I tell myself what to do, I'm much more likely to do it. So the coaching program is trying to get people to the aha moment of telling themselves what to do and how to preserve their vision and how to integrate their drop taking into their daily routine so that it becomes more of a habit and less of a burden, and how to kind of reimagine how taking these medications gives you power over your glaucoma as opposed to just, having to do whatever somebody else is telling you what to do. So that's at the core of our program is glaucoma coaching, where The coach develops rapport with the patient. That's the essence of motivational interviewing, is to have a good relationship. And the coach is trained in this specific type of motivational interviewing, but because we're not using licensed therapists or pharmacists or ophthalmic technicians, we have a script-based program to help guide the conversation between the coach and the patient.
And are they doing this just in clinic? Do they get follow-up calls repeated in between their visits? Or is it just a recording as a follow-up call? Who's doing this? Automated, a human being? And how often in between your visits?
So what we found from our interviews and focus groups is that people really wanted a person that they could talk to and that they could feel like they were developing a relationship with, and someone they could count on to help them connect to their doctor and to the clinic if they needed help. People really did not want a robot. I had a lot of people ask if I could just put my content in kiosks in the glaucoma waiting room. And I said, I don't think anyone will ever use it, but let me measure that during my trial and give you that feedback. And what it turns out, we gave 235 participants access to their coaching sessions and all the educational content online. And I may be wrong, but I think it was 2 people actually logged in. What that tells me is that people really value being walked through the education and having an opportunity to personalize it and identify with the content. So these are 3 in-person coaching sessions. The first is about an hour. And then 2 months later, there's another in-person coaching session that goes over again what problems people might be having putting in their drops, goes over again teaching eye drop installation if someone's having difficulty, goes over again making questions for their ophthalmologists, and goes over again how people are working, taking their eye drops into the habits of their daily routine. And then there's a third session that lets the patient touch on any topics that haven't been explored deeply enough or that they need more assistance with. And in between those 3 in-person sessions, the coach calls. They call first once a month just to check in. And as the person was in the program, their adherence was being monitored electronically, and the coach had access to this data. So those touch points were really facilitated by data. It was a data-driven conversation, which really will be wonderful for this remote therapeutic monitoring sort of framework where you say, Neil, I saw that last month your adherence was 50%, and this month it's 75%. What are you doing differently?
So who did you look at in this? Were these just people in your clinic? Was this across the nation? Who are the participants in the randomized trial?
So the participants were adults with glaucoma taking eye drop medications to control their glaucoma from either the University of Michigan Department of Ophthalmology or the Henry Ford Health System Department of Ophthalmology. They were not necessarily just patients from glaucoma clinics. They could be patients seen in the comprehensive clinic as well. We did exclude people who were going to have surgery in the next 6 months because that can really change your medication routine. And we also excluded anyone who self-reported better than 85% adherence on our screening question. 85% is the point at which we found that people's electronically monitored adherence is usually worse than 80%, which is the point at which we'd want to intervene. And we really wanted people who were willing to admit they had a problem, because if you can't admit that you have a problem, it's unlikely you're going to want to be coached. And then we want to really help people who are having a problem. If you're 100% adherent, you don't need to come and sit and talk to a coach about how to integrate drop taking in your routine. That's not useful for you. So part of personalizing the program really started with targeting who we're inviting into the program and personalizing who we're inviting into the program to make it relevant for them.
So how many people did this apply to in the practices that were recruiting these participants? Was it 1% of all the people that are being managed for glaucoma? Half of them? Who really would fit into this coaching program from the practices that were looking for these participants?
That's a great question, and it's something that we're still looking into. Of the people who self-reported poor adherence, about 2/3 were eligible and were able to participate in the trial. There was about 1,700 from that 300 that were not eligible due to various reasons. Could have been their adherence was better than 85%, or they were ineligible for other reasons.
So how many people ended up in the trial, and were they randomly assigned half and half to this standard care versus this coaching program?
We had 236 participants enrolled in the trial. One was excluded for screen failure, so 235 were randomized. We had 117 randomized to the intervention and 118 to the control. They were block randomized so that the study coordinators doing the assignment wouldn't know which assignment was going to come next.
So here we go. You came up with a potential coaching program. We want to try and improve medication adherence in these people in whom it's less than 80%. Some they're not taking it at all. Was it worth it? Did you improve anything? What was the outcome?
Yeah, the outcome was way better than I ever would have expected, honestly. Before we did the trial, I interviewed a bunch of glaucoma specialists from across the country and said, what change would it take for you to want to integrate a coaching program into your clinical practice? Trying to get a sense of what was my minimally important clinical difference that I needed to power this trial to identify in terms of change in glaucoma medication adherence. And what people told me is they wanted about a 17% improvement in adherence if it was going to be a major change in their practice. And that if it was going to be a really minor change in their practice, they would want to see a change as small as maybe 8%. So we powered the trial to detect at least an 8% change. And what we found was about a 20 percentage point change. So the intervention arm who received this personalized coaching and adherence feedback and adherence monitoring and reminders, they had a 78% electronically monitored adherence over the 6-month study period. And the control group who received those 3 mailings from leading educational institutions in parallel to the coaching sessions, they had 58% adherence at the end of the trial. That's about a third better. So I think that's way better than we had anticipated doing. And what really made me really happy was that we also decreased people's glaucoma-related distress. So that is the emotional distress associated with living with and managing a chronic disease, and it's taken from the diabetes literature. And we found that in the intervention arm, people's distress moved from a moderate level at the beginning of a program to a mild level at the end of the program, and the people in the control arm stayed at a moderate level of distress through the whole thing, before and after. So that to me was just a really significant impact that we were able to, by giving people extra attention and by making the attention very pointed and helping people address their barriers, find their facilitators, find their motivation, work things into their routine, have an avenue to improve communication, feel supported, we were really able to decrease the distress of living with glaucoma and improve their medication adherence, which, will then improve their outcomes.
So that's a large increase in adherence from, let's say, 58 to 78%. Is this available now to the public, or that's a step that still has to be attained?
It is not available yet to the public. I am hoping that in my lifetime, this will move from something that is in a clinical trial to something that we see implemented in people's clinics. We're currently implementing a pilot version of it at the University of Michigan, just to try to see what are the barriers and facilitators to local implementation. And I hope to engage in a larger implementation study to see what are implementation strategies that we might use to get this into clinics throughout the United States.
And in the long term, do we know if this will actually affect visual field loss or changes on the optic nerve, on OCT? How will we get that information?
If we can have a wide enough implementation study, then we could probably have enough participants and enough power to detect changes in visual field and intraocular pressure, which are both very, very noisy endpoints. And potentially RNFL, or the retinal nerve fiber layer. I think that is definitely in the works. One of the hurdles to getting there is developing a way to measure glaucoma medication adherence that is highly accurate and very scalable, because the adherence monitors that we used in this trial were quite expensive. And so we need to find kind of reduced cost technologies in order to enable wide scale testing of this approach and potential future implementation. So that's another area of work.
And were there any dangers to this? Did somebody get so upset with their coaches that they said, I'm not taking any of these anymore? Or you just didn't identify any true safety problems?
We did not identify any true safety problems. I think, we had more attrition in the coaching group than we did in the control group. And I think it's a time burden. So folks who either had competing issues or if they didn't like us and they didn't want to tell us, they would drop out. So that is something that will happen. And I think that's about as much of a safety concern as one can possibly have. But no, there's no safety concerns in an intervention like this, which makes it rather attractive given its impact.
And finally, you and your colleagues at University of Michigan and others around the country have always told us to be sensitive to costs of any interventions. What might it cost to bring on these coaching programs on top of what we're doing? Of course, they may be very worthwhile, as you pointed out, but what might be the cost of something like this annually to an individual?
That's another paper that's in the works, actually, is to look at implementation of this program. One of the things that's really exciting is that I think it was 2021, they changed the chronic disease self-management support reimbursement codes to go from reimbursing health coaching for chronic disease self-management provided by a non-physician provider. At first, you had to have 3 chronic conditions to qualify for insurance to pay for any kind of coaching support. And in 2021, they changed it to only needing to have 1 condition, and glaucoma qualifies as one of those conditions. So this is actually something that has a reimbursement pathway.
Well, this has just been wonderful. I want to thank you so much for joining us. I'm Neil Bressler, and I've been speaking with Dr. Paula Ann Newman-Casey at the University of Michigan on a randomized clinical trial that they've published in JAMA Ophthalmology on the effect of the Support, Educate, Empower Personalized Glaucoma Coaching Program, also known as the CSEE program, on medication adherence. Paula Ann, thank you so much for joining us and sharing this with us.
Thank you so much, Neil.
You can find a link to the article in this episode's description. This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thank you, everyone, for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.